I'm seeing people are logging in, so very good evening to everyone. And today it's my great honor and privilege to welcome our section chief of non-invasive cardiology, Dr. Kamu Maganti, who will be today's host for today's grand rounds. And she has a very special friend whom she has brought in from Northwestern as our grand round speaker for today. So for further proceeds of today's grand rounds, I welcome Dr. Maganti to go ahead. Kamu, welcome.
Thank you so much, Dr. Sengupta, for that kind introduction. It's been my pleasure to have known Jim, Dr. Flaherty, for a while, ever since he was a fellow. I actually saw him when he was pretty young, a little over diaper stage, of course. And I have to say, he's been one of these wonderful people who's managed to wear all the trifecta that we talk about in cardiology. He's a phenomenal clinician, a very good operator in the cath lab. And as Jim had told me, we've gone through a lot of alcohol together in the cath lab with all those septal ablations that we had done. He is a phenomenal structural, proceduralist, as I would call him. And also has been able to do a lot of research, has been published widely, very well recognized as a teacher. So it is my pleasure to welcome Jim to give us the grand rounds today. But before we get him started off, I'm going to share a little bit of information with all of you about the cardiology grand rounds. For those of you who will not be able to attend the entire conference, you should be able to see it on YouTube. And I am not able to share these slides with you with the YouTube link attached.
I'll help you. I can bring this over so that let me share it with you. Hopefully we can.
So the very first slide has the YouTube link. So just in case you miss a portion of the cardiology grand rounds, it's all recorded and you should be able to get to the link and be able to see it. Now the next slide is going to talk a little bit about the CME credits for this session. Just remember to text to the number that is there within 12 hours. And please text it as an SMS message, not an iMessage. And just remember, for you to be able to claim CME, you have to have an active profile in the Rutgers Cloud CME platform. So the next slide is going to go over the MOC points for physicians. There is a brief quiz. I tested it out and it's working beautifully. Just remember the room code future 41. So nobody is going to forget future, the wrapper. So it's future 41. And it's the same eligibility requirements as the CME. So you have to put in your ABIM ID as well as your date of birth. And so both of those are once again represented in the very last slide. So this is pretty easy to do. And if you guys have any questions, don't hesitate to reach out to Dr. Yanamala. She's able to troubleshoot everything I've learned. So with that, Jim, we are waiting to listen to this wonderful presentation you have for us.
Thank you very much, Dr. Sengupta and Kamu, for the kind introduction and the invitation to speak. The pleasure to join this group. Here are my disclosures. They're just about trials that we've participated in, nothing financial. So, when I was asked to give,
I think we are not able to see the slides, Jim.
Okay.
So let's try one more time.
Let me share again. I had shared earlier. I'll share again. How's that?
Great.
Am I on the right side? Is it the presentation?
Perfect. Yes.
All right. Thanks for catching that. So I'm going to talk about new paradigms in cardiovascular medicine. I know it's very broad. So I'm going to start with some principles and then hone in on a few areas that I've had the opportunity to be a part of, Camus as well, and try to illustrate, where we've been and where we're going in a lot of areas of cardiovascular medicine. Here are my disclosures, just some research trials that have been involved in over the last few years. A lot has changed in the last 25 years in cardiovascular medicine. Here's an illustration in the valve side. This is kind of what we were doing for valve disease 25 years ago. There were a couple of balloon procedures, but everything was mostly surgical. And now the landscape has changed dramatically. What do patients prefer? Well, they want to be up and out as soon as possible. So a lot of this is patient-driven, a lot of it's technology-driven. And for the most part, it's been a great revolution in terms of what we can do now that we couldn't a few decades ago. So I broke down this into a number of different paradigms. This is not meant to be completely comprehensive because there's probably things that everyone in the group could add to this, but I wanted to put some framework around this. Pharmacology, catheter-based therapies, imaging, phenotyping, genotyping, and AI, all big areas that really have expanded tremendously in the last couple of decades. Whether it's cardiac MRI or intracardiac echo, different drugs to target very specific diseases like tafamidis for amyloid, lots of percutaneous catheter-based and EP procedures that didn't exist years ago, a whole field of interventional heart failure that I'm going to speak about. Categorizing diseases more specifically, understanding them better, breaking things down into stages, looking more at the genetic basis of certain conditions to guide therapies. And AI, I know you have local expertise at this, but this is something that may change the future more than any of these other categories. A lot of this is coexisting with the emergence of the heart team. Instead of one silo of medicine taking care of everything, it's really a lot of our current care revolves around a whole team of different disciplines coming together with the patient at the center. And some might say this started with tumor boards in the 60s, where clinicians and nurses and everyone would get in a room and talk about a patient and options. Now we really do this routinely in cardiology, whether it's TAVR or other valves, shock, revascularization, pulmonary embolism. There are others that you can name on this list. There's really, it seems like we're always having team meetings, getting everyone involved, coming to group decisions in a way that we didn't do 10 to 15 years ago. I mentioned interventional heart failure, which is a newly recognized field. Now, GDMT has really been great and the cornerstone for HFrEF, and it's had an increasing role for HFpEF, but we know that clearly it's not enough. And HFpEF itself is a heterogeneous group of conditions. It's not one condition, and there's no one-size-fits-all therapy for heart failure in general. GDMT and other established therapies have changed the landscape, but there's still a gap. And some of that gap is being addressed by the field of interventional heart failure. And here's a schematic that shows some of the device-based approaches to different components of heart failure, whether it's renal pressure optimization with tiny axial devices that can increase renal blood flow. This is probably the beginner of interventional heart failure, the CardioMEMS, direct PA monitoring to help keep heart failure patients out of the hospital. Ventricular restoration is enjoying a little bit of a comeback with some novel percutaneous approaches to decrease the LV size. Renal venous moderators to decrease CVP and and improved renal perfusion. This is a study looking at subclavian obstruction temporarily to decrease preload and decongest patients with heart failure, and intra-atrial shunts, which is something I'm going to focus on in a little more detail for today's talk. This is work done by a colleague of Hemodynamic, Sanjeev Shah, who's really a pioneer in the HFpEF space. Sanjeev and his group did these heat maps with all these different clinical characteristics of HFpEF patients, trying to figure out where there are similarities and differences. And they came up with 3 fairly distinct groups that had very different trajectories and in natural histories. Group 1 was younger with moderate diastolic dysfunction, lower BNPs on average. Group 2, more obese, diabetic, sleep apnea, and worse diastolic dysfunction. And group 3 seemed to be older with more kidney disease, heart remodeling, and pulmonary hypertension. They're also looking at different comorbidities and inflammatory markers and different organs that are affected in the HFpEF syndrome, and how to strategize, how to take all this at the cellular molecular level and target therapies specific to individual groups of patients. And that introduces the concept of exercise-induced left atrial hypertension. And here was an early study. In fact, it was so early they called it HFnEF. It wasn't even HFpEF back when this study, this landmark study was published in 2010. Really, and these were patients that were with HFpEF, called NEF, were put on a recumbent bike with the right heart cath, and exercise was done and looking at the response. And you could see that the heart failure patients could not augment their stroke volume as well, but their wedge pressures had this steep incline. And that got people thinking about Lutenberg. And Lutenberg is credited with the observation first described anatomically by Johann Meckel that sometimes mitral stenosis and an atrial septal defect coexist. And when they do, Lutenbacher surmised that the mitral stenosis is a bit more tolerated through a left to right shunting mechanism. So unloading the left atrium became of interest. And here's a very elegant study by Barry Bullong and his group looking at sodium nitrite during exercise. And you can see that giving an infusion of sodium nitrate to those on a recumbent bike with right heart cath got them back on a normal curve of slightly elevated pulmonary pressure with exercise and increased stroke volume, increased cardiac output by unloading the left atrium. It's not practical, though, to hook somebody up to a bag of sodium nitrate every time they want to exercise. So this is a concept, not a solution. Other observations in this area included the observation that sometimes when you close an ASD, patients don't like it. They get elevated left atrial pressures. And balloon septostomy for years has been a bailout procedures, particularly in patients on ECMO that can't get off of it. So that begged the question of a lot of investigators, what would happen if you intentionally created a shunt in HFpEF patients? And that brings us to the reduced lap trials. The first one was a safety concept trial, and the second one was a large randomized, importantly, sham control. And the way the trial worked is patients got on a recumbent bike with a right heart cath. They had to have, all they really had to have was an LEF of at least 40% and a wedge that went up to at least 25 with exercise. There were some exclusions, but these were the principal concepts. If they met these conditions, then an intracardiac echo was done to ensure that the septum had adequate anatomy for transeptal puncture and device placement. And at that point, they were randomized to either intra-atrial shunt device or ongoing medical therapy. And They were shammed, so they had headphones on and they were blinded, and they stayed blinded throughout the trial. The diameter of the shunt was carefully calculated to prevent any excessive RV loading, right-sided loading at 8 millimeters diameter. Here's an example of a case we did. 71-year-old woman with HFpEF. She got on the recumbent bike, got her wedged to 27. Here you can see the ICE catheter and the device going across. And here's two views of the shunt device. Now, for anyone that's ever been involved in PFO or ASD closure, this is very similar, relatively straightforward procedure. This part of it takes about 30 minutes. The bike part is the more intensive work, getting them all situated on the recumbent bike. So what happened with this trial? Over 600 patients, half got device, half got sham. Composite endpoint of CV death, stroke, heart failure events, and change in KCCQ quality of life scoring. It could have been more neutral. Win ratio of 1, right on the line. Here's the heart failure outcomes. There was an early signal of benefit with the shunt, but it kind of went away after a year. Safety was very good. So everyone was scratching their heads, wondering what happened. We had all this data that unloading these patients was going to be a benefit. So they went back and dug deeper, and they found that about half of the group had pulmonary exercise-induced pulmonary hypertension with PVRs that were not high at rest, but got high with exercise. And also the group of patients that had pacemakers did not respond. And actually, not only did not respond, but these groups, those that had a pacemaker and a high PVR with exercise, actually did worse. They're indicating that their right side did not respond favorably to the shunt. Yet, when you take these patients out, it's only two characteristics. Half the study group stayed in. The win ratio went from 1 to 1.5. Heart failure events went down 45%, and KCCQ went up 55%. So how did they respond to this? Well, they designed another trial, the second round, and that's going on now. It's smaller, same inclusion, a few exclusions though. You cannot have a PVR that goes greater than 1.74 at exercise, and you can't have a pacemaker. And they're not looking at safety, because safety was well established. So they're just looking at heart failure events and change in KCCQ. And this trial is already enrolled. We've already enrolled a handful of patients. But this is a really important trial in interventional heart failure. There's about 5 different trials looking at different types of shunt devices and targeting exercise-induced left atrial hypertension. So in this trial, I would say was very elegantly designed, almost to a fault, because with the shams, it really eliminated a lot of potential bias that historically we've had in trials where the patients were unblinded and knew whether they got a drug or a device. So this was completely honest trial. It didn't work, but they learned a few important things. They learned that there is a concept of exercise-induced pulmonary hypertension that wasn't really understood well before. So a lot of people holding their breath on this, but it's really fun to be a part of this. So that's my introduction to interventional heart failure. It's a really fun and emerging area, but I wanted to shift into some of the valve stuff that's really exciting. And we all know about TAVR and the success that's revolutionized the treatment of aortic stenosis, and about transcatheter edge-to-edge repair for primary and secondary mitral regurgitation, and the remarkable results of the COAPT trial for functional MR. The new kid on the block, and it's been around for a little while now, is tricuspid regurgitation, something that we frequently ignored in the past. However, it has a prognosis that rivals aortic stenosis. By some estimates, 1 year survival is only 64%, and the worse the regurgitation is, the worse the prognosis. And by this data, you know, within 5 years, you can go from mild to severe. And as you can see, as soon as you get to severe, you really drop off the survival curve. And the change, here's some of the risk factors: pulmonary pressure changes, atrial fibrillations, and coronary disease promote further TR. And it's independently associated with subsequent mortality. So a recently recognized really important area of cardiovascular care is tricuspid regurgitation. What about surgery for it? Historically, patients have done very poorly. High operative mortality rates, very low case rates, major morbidity. A lot of this is because they have concomitant liver and kidney disease, and that renders people poor operative candidates. By some data, even those that get tricuspid valve surgery with another operation, whether it's bypass or another valve, they do worse than those that didn't require tricuspid, at least observationally. There's a lot of trials looking at the addition of tricuspid valve repair to, say, mitral valve surgery, and to really understand how beneficial that is. But because these patients are such poor surgical candidates in many instances, it's led to enthusiasm for percutaneous therapies. And one thing that's come out of this is understanding that our old kind of eyeball grading system of mild, moderate to severe TR is insufficient. And Rebecca Hahn has been promoting this for years to try to get an accepted grading system that really breaks the severe cases into 3: severe, massive, and torrential, to really better quantify how much TR there is. And I think this has become accepted nomenclature, and it's been used by all of the pivotal trials, a 5-scale grading system for TR. This cartoon looks like the tricuspid valve has very nice anatomy with 3 leaflets, but you can see here that it's surrounded by important structures and conduction. The right coronary artery courses along the anterior and posterior leaflet, and that becomes important for some of the therapies. The truth is that there's a lot of variety in the tricuspid valve anatomy, a lot of chordal variety and papillary variations. Sometimes you could have 4 and 5 leaflets, not just 3. So it's really not like the aortic valve or even the mitral valve in terms of predicting what it's going to look like. Here's a cartoon of the landscape of some of the devices that have been developed and tested. There's TER devices like the MitraClip and Pascal that have been studied heavily in the mitral space. There's annuloplasty devices that try to mimic the surgical repair with an incomplete ring. There's valves that can be implanted directly. And then cable devices that have fallen out of favor a little, but there's still an investigation where you, one way or another, you exclude either the superior vena cava and the inferior vena cava, or both, and try to basically isolate the right side almost in a congenital way. So I'll show a few cases of examples of how you may think about this in terms of what device you may see working and what kind of anatomies. Now here's a 61-year-old with a transplant, had a flail, posterior septal leaflet. You can see here this is likely, although I don't think it was my fault, but it's likely a biopsy injury. The annulus was just mildly dilated, the TR was torrential, the leaflet lengths and the gap were fairly narrow. Here's some color flow, seeing a really broad jet of tricuspid regurgitation. So the anatomical choice here was transcatheter edge repair. And I'm not sure if this was a randomized case, or I think this might have been a registry case, but you can see the TEER device in there with and without color, and you can see that the regurgitation really got down to mild. Very successful application of TEER for tricuspid regurgitation. And here's some of the early experience in the Triluminate registry using the MitraClip, which is now the TriClip, specifically designed for the tricuspid space. If you've been in this space or read up on it, you can get familiar with these graphs. They can be a little dizzying, but basically what you see here is that at baseline, most patients had massive or torrential TR, and at 1 year, it did go away with TR, but it was better, and it was sustained better. In most cases, got it down to mild to moderate. In some cases, still severe. In some cases, still massive torrential, but the trend generally was successful. And at least in this cohort of 65 patients, there was a corresponding increase in NYHA heart association class that was seen through the first year. Now there's two tier devices that have commercial approval for the mitral space, and they have approval in Europe for the tricuspid space, and the other device other than the TriClip is the Pascal device that is a little same concept, but a little different design on how the leaflets are pulled together. And this is the early experience with that, which is now in a broader trial that's still ongoing. Kind of similar story. It gets the tricuspid regurgitation down substantially, but doesn't eliminate it. And there's a corresponding improvement in NYH heart association class. Well, many of you probably saw this last month, published online in the New England Journal of Medicine. This was the randomized TriLuminate trial, looking at TEER with the TriClip device versus medical therapy alone. A broad composite of outcome of deaths, tricuspid valve surgery, heart failure hospitalization, or significant change in KCCQ score. And at 30 days, there was no doubt that TEER was effective in 87% of patients, getting it down to moderate or less versus only 5% in the control group. So this tells you that the procedures were successful and the TR was significantly reduced. The win ratio was 1.5. However, it was almost entirely driven by quality of life and not the harder outcomes like death and hospitalization, rehospitalization. And the better the reduction in the tricuspid regurgitation was, the bigger the increases were in quality of life. So all we can really say from this trial at 1 year is successful TEER and severe TR had a significant and probably meaningful impact on quality of life. So is this a win? Was the trial too selective? Do they not have sick enough people? About half of them were screen failed for either clinical or anatomical reasons. Do you need a sham arm if you're going to rely on quality of life? Like we showed in the reduced LAP2 trial, that the sham arm really can change the perception of patients and clinicians as to how someone's responding to a therapy. Is this a Hawthorne effect? Because patients know they're being watched because it's open label, and quality of life has some subjectivity to it. And is 1 year long enough? These patients are going to be followed 5 years, so we'll be following the story for the next few years to see if gaps narrow or gaps widen in terms of the outcomes. So I'll move on to a different case. 75-year-old persistent atrial fibrillation, severe annular dilation, massive TR. He's got a short restricted septal leaflet. Here's an echo, a TEE. You can see quite a bit of jet and restricted leaflet. So the choice here was transcatheter tricuspid valve replacement. And here's some images of the procedure. After doing a dozen or so of these, with the current equipment we have, these are pretty quick procedures. Most of them can be done in under an hour of device time. These anchors for this valve, and I'm not naming devices because they're all investigational, but you can see this sits across the valve, and here it is deployed in a nice 3D beautiful view. And here's some color flow at the end. Really, there's no TR. It totally eliminated the TR. So as opposed to the TEER strategy, you get really dramatic reductions in the TR with valve replacement. You can see here that the vast majority went down to trace or mild as opposed to those that were maybe mild to moderate with TIR. These are traced to mild, and also a corresponding bump in improvement in terms of symptoms. This device, the Evoke device, which is shown here, was fairly safe. There's a small risk of pacemaker, given that that AV node is right behind the annulus. But all-cause mortality in a very sick group was only 7% and low hospitalization. So it seemed to meet most of the safety qualifications. And recently at London Valves a few months ago, the global registry of 176 patients was presented. Implant success was 96%, low mortality and hospitalization at 1 year. 98% had less than or equal to mild TR. That's really impressive. And for quality of life, the jump here was even substantially more than we saw in Triluminate, 25 points. And for those that are in the quality of life arena, that's a substantial jump in addition to the 56-meter walk improvement. So that was the segue for the pivotal trial, which is a randomized with a 2-to-1 scheme for the Evoke tricuspid valve against optimal medical therapy alone. These are going to be followed for 5 years, and about a month ago they completed enrollment. So, and there are other valves out there too, as I showed originally. I think this and some of the other trials are really going to answer this question as to if anatomically suitable is valve replacement, since it has a more complete effect on TR elimination. Is that going to be the way to go? Case 3, 71-year-old woman, coronary disease and AFib, massive angular dilation, severe to massive TR, large coaptation gap. So with a massive annulus and a large gap, not good for valve replacement, not good for TIR. Wide open TR. The choice here is going to be annuloplasty. This is the most difficult of the 3 procedures. It's very time consuming. You can see there's a wire in the right coronary artery because the right coronary artery will lie adjacent to the annulus in most patients and can be compromised. You've got to watch that during this. And these pledgets go in one by one. Usually it's a total of 17 to 18, and they form an incomplete ring. This, of all the procedures, requires very precise collaboration with echocardiography and TE guidance. At the end, when they're all in, there's a string that pulls them together and crimps down the annulus. Shot of the right coronary at the end to make sure it wasn't compromised. This is actually the 1-year echo on this patient, and the TR was graded as moderate, went from severe massive to moderate, which is kind of what you get for this. Here's the early experience, 30 days, most torrential and massive, and really got it down into the severe moderate range at 30 days. However, interestingly enough, when these patients were followed out longer, their annulus continued to shrink. They probably responded better to medical therapy and diuresis. And their TR didn't creep back, but it continued to get better. You can see the proportion of severe became more moderate as time went on. So really with time, this therapy improved. Another aspect of annuloplasty is that it could serve as an anchor for valve replacement in the future if the TR came back. Now you have a nice metal anchor to put a valve in. So there's a lot of unanswered questions about this, as exciting as it is. What are the appropriate targets for the trials? Is it quality of life, mortality, rehospitalization, something else? How durable are the results? Should we be treating earlier? When you take patients in a trial that have liver and renal failure, it's going to be tough to really turn them around. Which modality is going to win out, or are you just going to have to pick and choose depending on clinical and anatomical criteria? Are these valves durable? this is not often a population that you're going to want to put on long-term anticoagulation, and it's a low flow state, and you wonder how durable leaflets will be without anticoagulation. Now, TEER has run into problems on the mitral side because it can block future procedures. There's ways around that, but in general, when you put a metal-based device in the middle of leaflets, it gets crowded to do future interventions on there. And maybe the broader question is, do we need to be more aggressive before we get to the need for intervention? Getting people out of AFib, free their pulmonary retention, stop putting pacemaker wires across the tricuspid valve. So maybe there's a lot that needs to be done on the front end to reduce the need for some of these bailout interventions. All right, so that gets me into my last topic. And when I saw that your grand rounds were later in the afternoon, I thought this would be an appropriate topic: on-hours uses of alcohol in cardiology. The alcohol has a rich history of medicinal use, dating back to Villanova. He said, "We call it aqua vita, and this name is remarkably suitable since it is really a water of immortality. It prolongs life, clears away ill humors, revives the heart, and maintains youth." Now, tragically, he died in shipwreck, and it's unknown if alcohol was involved in the accident or not, but still, you can see that it's been used in a lot of different health areas, including cardiac procedures. Everyone is familiar with alcohol septal ablation. Kamau Magani and I did several hundred of these together. Ulrich Sigwad was first credited with this in 1994 out of the Royal Brompton in London. And he actually, by legend, the first attempt an alcohol septal ablation was by one of the Brugada brothers to try to treat a septal pathway for VT. And someone noticed that it didn't get rid of the VT, but it got rid of the basal septum. I'm not going to belabor this part of it. It's very effective in sustained reduction in gradients. There's an endless debate about whether it's comparable to surgical myectomy. This meta-analysis suggests that they are. Certainly, there are a lot of patients that either refuse or are not good candidates for surgical myectomy, where this is a really good therapy. But I wanted to talk about how alcohol ablations have gotten life in other areas. There's a concept that we learned in the TAVR world, so suicide left ventricle, when you get flow acceleration after putting an aortic valve in. Now, we knew about this in the pediatric population after pulmonic valve procedures. Patients could collapse and go into shock. But it was first described in the aortic space, 2010, after a TAVR. And it doesn't have to be in patients that have hypertrophic cardiomyopathy or necessarily a very prominent basal septal or SAM at baseline. It can occur right after TAVR or hours later. Here's a case from my friend Amar Krishnaswamy at Cleveland. He had a 91-year-old Severity S, 60 millimeter gradient, did the TAVR, and 2 minutes later she was in shock. They looked at her hemodynamics, so you can see the tracing change from a valvular to an outflow tract problem. She developed SAM. So they did an emergency alcohol septal ablation, got her out of shock, and she survived this. If you've done TAVR long enough, this has happened to you, this suicide left ventricle, and it's very frightening. So we've gotten in the practice occasionally of preemptively doing alcohol ablation to try to prevent this very catastrophic outcome from happening. That moves us to the mitral space, the concept of the neo-LVOT for transcatheter mitral valve replacement. And that's a situation where the long anterior mitral leaflet after valve replacement gets pushed in to the LV outflow tract and can cause obstruction. And this also can be catastrophic. We measure this on CT scan to see how much neo-LVTO space we have. And it's not perfect, but the accepted area is at least 200. But this has been the #1 reason for turnaround for TMVR. But there are ways to reduce the risk. And the #1 way is to do alcohol septal ablation. There's also radiofrequency septal ablation for those who don't have suitable anatomy. And there's a new procedure that's being studied, the Sesame, where you do a guide wire assisted radiofrequency septal laceration. Originally, the original surgery for hypertrophic cardiomyopathy was not myectomy, it was myototomy, where they would just slice down the middle of the basal septum towards the apex, and this is mimicked in this procedure. We'll see if this takes off, but it's a very creative procedure by the group that's come up with a lot of the electrosurgery techniques, including Lampoon, which is another technique where you cauterize the anterior lethal and mitral valve so that it's split in two and it will not completely obstruct the LV outflow tract. And there's others as well. So here's a case of an 83-year-old man who had a mitral valve ring. Now he had real HOCM. He had a basal septum of 2.6 and a real outflow tract gradient. And his neo-LVOT by CT was 170. Had new MR and severe heart failure, was deemed inoperable. And Kamau, I think you may have done this case with me. Here we are getting into the first septal perforators here. You can see a wire here. You can see that that wire is adjacent to the ring, delivered probably 1.5 cc's of alcohol in there, got his post-PVC gradient down to 4 and his neo-LVOT greater than 200. 3 months later, usually wait at least a month, re-image them, and then we can do this. 3 months later, he got a successful valve and ring procedure. Now I'm going to shift to the world of EP and alcohol, which is brand new, at least brand new for me. I didn't know what the vein of Marshall was, or if I did, I forgot about it, but it's an atrial branch of the coronary sinus. It's a remnant of the left superior vena cava, and it runs posteriorly superiorly in the left atrium, the left pulmonary veins in the appendage. Here you can see an angiogram of the vein of Marshall. Now this area supplies perimitral space that can be very difficult to get to with catheters for AFib, flutter, and ATAC ablations. And the way this procedure is done is a catheter is introduced into the coronary sinus, an angiogram is done, and then a coronary wire, catheter and wire, and a balloon are then introduced into the vein of Marshall, and alcohol is given up to 4 cc's, depending on the branching pattern, how big it is, over a period of about 10 minutes total. This was studied in the Venus trial, about 350 patients going AFib ablation. They were randomized. The alcohol was only delivered in about 84% because some people don't have suitable anatomy. And the 12-month freedom of AFib or ATAC was over 10% higher than those that didn't get the alcohol. And the AFib burden overall was substantially less. So in some EP labs, this has become very standard. Some are getting it in all their ablations, certainly those that fail AFib or AFlutter or atypical AFlutter ablations. Here's a case, 64-year-old, had AFib, cryoablation, kept recurring, failed drug therapy, then had atypical flutter, kept coming back. Here you can see a wire in the vein of Marshall. He underwent a standard ablation, and then we put 3 cc's via balloon catheter right there. You can see the kind of contrast, the contrast injection here up the vein of Marshall. And here's the map after. And you can see the purple. You can see this is catheter ablation. There's an area that could not be reached and really completed the ablation with alcohol. And this, I think this cured his AFlutter. So really interesting stuff. And it seems like this is now a real part of ablative therapy in the EP lab, which brings us to LV summit arrhythmia. And the LV summit is the triangular region that sits anatomically between diagonal and obtuse marginal branches off the LED and left circumflex respectively that is impossible to reach for epicardial VT or PVC ablation. However, there are branches off the coronary sinus that can map out these areas. Here's a case: 42-year-old woman. She had an LVEF of 25%, a PVC burden of 35%, underwent an ablation and got better, but then she got worse again, despite repeated ablations. And her PVC burden got back up to close to 20%. There are some clues on the surface ECG that you might be dealing with this focus, such as the pseudo delta wave, this V2 pattern, QS and lead one, initial R wave and lead one. This predicts an LV summit location. And here it is. You can see this right bundle morphology and axis there. And here we are in the EP lab. Here's a coronary sinus phenogram. And my electrophysiology colleague, Nishant Verma, skillfully got a microelectrode into several of the branches, the distal septal branches, way down the coronary sinus. And he mapped out the same morphology of PVCs that was seen on her other tracings. So then we traded this out for angioplasty equipment, delivered 3 cc's of alcohol in 15 minutes. She had chest pain on the table, which we felt like she was at least getting some effect. And then 6 weeks later, she had virtually no PVCs. So really exciting stuff. Really creative uses of alcohol beyond what Kamu and I did for years and years doing alcohol septal ablations. We're now tipping over into the EP lab and helping ablate some of their tough to reach arrhythmias. So in conclusion, last few decades, cardiovascular medicine undergone transformative paradigm shifts. The heart team and other interdisciplinary alignments have shifted us from silo-based to collaborative care. HFpEF is a heterogeneous syndrome that demands targeted therapies and has really brought out this new field of interventional heart failure. Severe or worse tricuspid regurgitation represents a historically unmet need, and the rapid advancement of transcatheter TR therapies lends promise towards alleviating this. And the medicinal use of alcohol and cardiovascular medicine is moving beyond the treatment of hypertrophic cardiomyopathy into an array of creative spaces. So with that, cheers, and thanks so much for having me.
Jim, thank you so much. I feel as though I've learned a lot. We've all learned a lot. I'm sure that many folks have a lot of questions, and I'm going to start off with one question of mine. What is it about pacemakers that makes patients not respond to interatrial shunt devices? Do you think that there is some changes in the RV or is there some changes in the just the way the conduction system is put under pressure? Is there something, or is it a combination of both?
You know, it's interesting. It bridges some of what I talked about with tricuspid regurgitation therapies, where these patients get TR and they get right-sided chamber remodeling that's adverse. So there's something about pacing the RV. Not only does it cause TR, but it causes RV dysfunction, negative remodeling, probably changes in right atrial geometry. And it's probably that right atrial and right ventricular myopathy from chronic pacing that is unmasked by the shunt. That right side does not accommodate the shunt created in the reduced lap trial. So I think that was not well understood. And that's one hypothesis, is that, and you can't see this stuff very well all the time on echo, because high right atrial pressure was an exclusion criteria. It was greater than 14, but there are hemodynamic changes that occur with exercise that weren't measured in the trial. We weren't measuring what happens on the right side of the right chamber pressures during exercise.
If it's okay, I have one more question. Do you think that the leadless pacemakers might change the landscape when it comes to both tricuspid regurgitation as well as some of the RV remodeling that we see due to secondary TR?
Yeah, I think that the leadless pacemakers are definitely going to have a role, and more of a role. You know, there are challenges with them in terms of, you know, you can't really take them out now, although there are modifications to be able to take them out. Typically now, if a battery runs out, they put one next to it. But now there are newer models that are going to have atrial sensing. Traditionally, we've only used the leadless RV pacemaker for those that had AFib and bradycardia, because they didn't need that communication to the atrium. But newer models are going to already have communication and dual communication capabilities, and avoid injuring the tricuspid valve. So yes, I think His bundle pacing, although some His bundle can interfere with the tricuspid valve, coronary sinus pacing, and leadless RV pacing, all of these are going to be considered alternatives to a chronic lead across the tricuspid valve, which we know is detrimental.
No, that's excellent. I'm just going to see if others have any questions. And if they don't, I have one last question. I don't see too many questions in the chat. If anybody has any questions, please unmute yourself and ask them away. The other question that I have for you is the LV summit ablation is extremely interesting, especially when it comes to VT. How successful are we, and how commonly is it used?
For the LV summit
ablation, yeah.
This is brand new. I didn't know about this a year ago. There's some leaders that are really pushing this, but this is a brand new field, and it's only been around for a couple of years, so it's very uncommon. Most places are not doing these ablations. The key to be able to do this is the electrophysiologist has to be able to map out the anatomy, as was done in the case that I showed. You've got to be able to either get an electrode near or into the particular branch to know that you're getting the right spot. And just getting the right spot is not enough. Sometimes there's bigger branches that communicate, and it's a very complex procedure. You have to put balloons on both sides of the communication and put the alcohol in between. So this takes a lot of collaboration, and I think, but it works. So if it continues to work, then I think it'll grow into acceptance into the broader EP community.
Yeah, no, that is extremely interesting, because I kept thinking there is going to be a lot of parasympathetic innovation right there. And obviously it is vagally mediated, some of it, both for atrial arrhythmias as well as some of the VT. And
you can't get near it with catheter. You can't get near it with traditional radiofrequency catheters mostly because there's coronary branches that are overlying that area, and it's just not safe.
Yeah. To
do a traditional ablation in that region.
No, this has been such an excellent talk, Jim. Thank you very much. I'm sure there'll be questions coming in, and we'll hold them for when you get here.
Well, thanks again for having me. It was a lot of fun. I learned a lot preparing it, and I was able to review a lot of the stuff that we've done both you and I and the team here. And it's great to be able to share. If someone saw something new, that's exciting.
Yeah, I've learned a lot. Thank you again, Jim. Have a wonderful evening.
Thank you. Great to see you, Kamo.
Thank you. Bye.
Bye-bye.